Good evening, everybody. I can see people are joining us. Welcome. Tonight, or today, apologies, I'm in London. I'm being joined by Dr. Colin Schmeichel and Devon, who is an embryologist at Laurel Fertility Care in San Francisco, California. And we're going to discuss everything to do with embryology, and we have some fantastic slides and expertise to share with you tonight. And Dr. Schmeichel and Devon will be taking your questions as well. So thank you so much for sharing those in advance. I'm Eloise, and I'm the founder and editor of Fertility Help Hub. It is a lifestyle fertility platform which gives people around the world who may be at different stages of their fertility journey all the expert support and holistic resources that I wish that my husband and I had when we went through infertility treatment. He has azoospermia, Klinefelter syndrome, and we have 3 young sperm donor conceived children. And I'd like to introduce Dr. Colin Schmeichel, who's the medical director of Laurel Fertility Care.
Hi, wonderful meeting everyone. Hopefully we can provide some information that'll be helpful in terms of at least conversations about embryos, eggs, and all the aspects of the fertility lab.
And Devon, nice to have you on board as well.
Thanks so much for the introduction. So hopefully we can answer some questions regarding to what goes on here in vitro.
You can ask questions live. We'll also be going through the brilliant questions that people submitted in advance, so thank you for those. It will be recorded. If you have any questions, feel free to raise your hand. Also, you can communicate with us and the other participants through 2 chat boxes. And of course, if you want to stay anonymous, that is absolutely fine. Welcome, and please introduce Laurel.
I'm Colin Schmeichel. I'm the medical director at Laurel Fertility. We've been here now for almost 17 years, providing fertility care for women and couples from around the world. We manage patients with a variety of disorders: polycystic ovarian syndrome, tubal infertility, diminished ovarian reserve. We offer all the assisted reproductive services you can imagine, including from in vitro fertilization to different nomenclatures for genetic testing, which is PGD, PGS, CCS. But now the common nomenclature being pre-implantation genetic testing for embryos, for aneuploidy, for translocations, for structural rearrangements. Devon is our lead embryologist. We'll talk about some of those features as well. Hopefully that starts the conversation.
So basically what I want to do, I think for a lot of patients, it's kind of a mystery what happens in the lab. So I just want to run through some procedures, very common procedures that we do with almost all of our IVF patients, show you a bunch of pictures, and hopefully this will make what we do a lot more transparent. So if you look down the column there on the left, what we're going to run through is basically egg collection. We're going to see how many of those eggs we can use, run through the fertilization process that we use most commonly, which is ICSI. We use it in almost all of our patients these days. Fertilization check, we're going to monitor the embryos for 5 or 6 days. I'm going to show you some procedures we do involving assisted hatching using a laser, embryo biopsy for what Dr. Schmeichel was just talking about for pre-implantation genetic testing, and then lastly, freezing the embryos. This is a picture that I took just a few days ago, a bunch of eggs in a dish. So if you look at the left picture, you can see 1, 2, 3, 4, 5, 6, 7 eggs there. The little dark center is the egg, and around it are all the supporting cells. So I've blown up one on the right so you can see it more clearly. The very large cell in the center is the egg, and around it is what we call the cumulus cells. So those are nurturing, supporting cells that help the egg grow and develop. This is what it looks like when the eggs are collected in the lab. This is what we call oocyte denuding or stripping. What we basically have to do in the lab is remove all those cells around the egg using a very thin pipette and pipetting the eggs up and down with the help of an enzyme. And what we're left with is what you can see in the bottom video right there. We're left with just the eggs alone, just the cells, without any cells around them. And that way we can assess their maturity. What we started with is on the left with the egg in the center and all its cells around it, the supporting cells. And what we're left with at the end of the cleaning process is what you can see on the right, which is the naked egg alone. And this way we can tell which eggs are mature. In other words, which eggs are ready to accept a sperm and which eggs are immature. So how many eggs can we use out of the ones that are retrieved? On the left is a picture of an immature oocyte. So this oocyte is not going to fertilize in our lab as it exists when it's retrieved. The one on the right is mature. What we're looking for is that little polar body, that little bubble on the outside of the egg, right? Basically, what's happening is the egg is kicking out half its DNA and preparing itself to accept sperm and the DNA from sperm so it can fertilize. Another thing we do in the lab is we're going to look at the eggs and kind of grade them. How do they look? And this is indicate for us maybe or predict the success for some of these eggs. So at the top left, you can see what a normal egg should look like, and then some abnormalities that we witness in the lab. The most common being granular cytoplasm or vacuoles. Some studies suggest that it's diminished when you have very abnormal looking eggs after retrieval. After we perform the ICSI, we're going to check the fertilization, and this is done 16 to 18 hours after ICSI. So egg retrieval is done on the morning of day 0. The ICSI is done in the afternoon, let's say 2 to 4 p.m. We come in the next morning and we can see how many fertilize. What we're looking for basically are those 2 little circles in the center of an egg. Those are called pronuclei. And when you have 2 of them, that means you have uncondensed DNA from sperm and the egg, and they're sitting right next to each other, which is what you want to see. And that basically means that the sperm worked together with the egg correctly how you wanted it to. And those will almost always turn into an embryo. Now that we have embryos, we're going to go on to monitoring them day by day. You can see at the top left picture, that's the day 1 that I just mentioned with the 2 nice pronuclei right in the middle of the egg. On day 2, the embryo should be 4 cells. This is normal development. On day 3, it should be between 6 and 10 cells. On day 4, you can see it comes together to form, it almost looks like one big cell, but they condense, it's what's called a morula. And then what happens is the embryo rapidly expands and becomes what's called a blastocyst, which you can see at the bottom right there. And that will happen sometime between day 5 and day 7, hopefully. And it's important to mention the largest drop-off that we see and that all clinics see is between day 5 and day 7. So if you have 10 eggs that fertilized on day 1, you will most likely have 10 day 3 embryos that look like that bottom left picture. On average, you'll have about 5 or 6 blastocysts. So there is a drop off between day 3 and the blastocyst stage. So this is a procedure we do in the lab here called laser assisted embryo hatching. What we're doing is just using very small, delicate infrared laser, and we're going to poke a hole in what's called the zona, which is a protein layer around the embryo right there that you can see. And what this does is, if we're doing genetic testing, first of all, it allows us to go into the zona and take cells for testing, and it just aids in implantation in general. So it helps the embryo hatch out of that zona layer that it has to and implant, basically. So now that we have our nice day 5 to 7 blastocyst, this is our grading system that we use in this lab. It's called the Gardner system. I think it's the most commonly used embryo grading system in the world. It's used by most clinics, I think. It's like, academia. So A is the best, C is the worst. And you can see by this graphic right here what we prefer, what we want. 5 is a partly hatched embryo. So an embryo that's partly escaped from that layer that I just showed you that we drilled a hole in. Or we want a 4AA, which is a totally expanded embryo, but just hasn't started to hatch yet. Here we find that those embryos, have a higher implantation and pregnancy potential. So even though, the C is red, disregard, I wouldn't say we disregard them. Here, actually, we have pregnancies from 4 BC, 5 BC embryos just about every month. Taking some pictures of embryos and then assign grades to them so you can see what I'm talking about. On the top left, that's what we call a 3AB embryo. So the 3, refers to how expanded the embryo is. I don't know if you can see this, but there's a cavity in that embryo that's about half full. And at the top left, there's a little circle in the middle of that embryo. That's the inner cell mass. So the first letter is assigned to the inner cell mass, and the second one is assigned to that circle of layers around the periphery of the embryo, which is called the trophectoderm. And the A is just based on how big it is, how consistent the cells are, basically how pretty it is. On the left is a 4AB embryo, so more expanded than the 3. And you can see on the 2 bottom pictures are 2 very good embryos. They're partly hatched. I gave them both 5AA, so you can see they take on that kind of figure 8 shape because they are partially escaping from the zona. And this is an example of a poor quality embryo. As you can see, there's very few cells in this embryo. There's very few cells in the inner cell mass. So this would be an example of a 4cc embryo. So next, I'd just like to talk quickly about the embryo biopsy procedure. Again, we use the same laser that we use for assisted hatching. And what we want to do is take a nice looking embryo like we have on the left and remove about 5 to 10 cells from it. So we want to get from the left, and you can see the cells up there at the top of the right picture. Well, we use that laser again, which is the red circle, and now the embryo is partly hatched out of that hole that we already made. So we're just going to hit it a few times with the laser, take a few cells away, and you can see them right there, and the embryo stays fine. If you looked at that embryo in 30 minutes, you wouldn't even be able to tell that we touched it at all. So it's not really harmful to the embryo at all. This way we can test these cells, that are hopefully representative of the embryo, and it's going to tell us the implantation potential. Lastly, I just wanted to show you what the freezing procedure looks like. So the embryos are microscopic in that drop, so you won't be able to see them. But basically what we're doing is moving them from body temperature to a very cold temperature almost instantly. And they're good like that for decades, the embryos. In any event, our freeze thaw success rate is almost 100% here. So any embryo that you freeze is going to survive here. I just wanted to show you, since we're talking about embryology, there's been a lot fairly recently about it and how it affects clinical outcome, right? So you can see the top left is a paper that was published recently that looks at different biopsy protocols. So that laser procedure that I showed you where we remove some cells, labs do that differently. And this paper looked at how that might affect clinical outcomes. The paper on the bottom looks at the intensity of the laser you use and whether that damages the embryo at all. And the paper on the far right looks at donor egg cycles from different fertility centers. The reason they looked at donor egg cycles is because donor eggs come from young women that are generally good responders, and they basically wanted to remove the factor that, a lot of what Dr. Smykel does with the stimulation and just looks at what happens in the lab itself and compare different labs. And they found that the number of embryos generated and the number of euploidy at the top left, you can see that in that paper, which means the number of normal embryos varies greatly between labs. So this means that what we're doing in the embryology lab, has serious implications for clinical success.
As I mentioned, we've had a lot of questions come in. I've seen a couple more questions come in live. So if anyone wants to ask anyone on the panel questions, please feel free to message them across now. In the meantime, I'm going to start by asking you some of the questions that came in before, if that's okay. So Devon, what does being an embryologist involve? You've obviously shared some of the work that you do in the lab.
It involves, great attention to detail, of course, and really just a mastery of those kind of procedures that I just went through right there.
I meant to say, as part of that question, we know that embryology is key for part of the IVF process and success. So why should people look for a clinic that has top-rate embryology team?
It's such a huge part of it. So let me just give you one example. I just looking at one aspect of the lab, which would be culture system. And one metric that I hope most labs look at is what's called blastocyst formation rate, right? So I mentioned there's a drop off between day 3 and day 5. The variation in labs based on how they culture embryos is huge, right? So this change could be 40, 30% in some labs and 60, 70 in others. So that means if you have 10 eggs and you get 8 embryos, you're either going to end up with 2 or 3 good embryos in the end, or 5 or 6, right? Double that just based on that one metric on culture system. And that's not even getting into procedures. That's just how well the embryo is growing in the lab.
Can I just follow up with a little bit more about, he's not quite telling you just in terms of what being an embryologist involves. I think it takes a lot more time to not only specifics and a lot of attention to detail, but it also has, a person has to have a background in basically being really meticulous and they have to have some sort of background in biosciences. You wouldn't actually have an art person going into embryology because it involves really having a lot in terms of being in the lab itself. Most embryologists are either going to have a master's in science or a doctorate in science for embryology. There's a lot of technical capabilities in terms of all those structures as well. So a lab will actually have a lab director that's typically either a master's in science or a PhD to manage that lab. They'll also have a technical supervisor, and they'll also have a technician within the lab or a junior embryologist. All those are actually managing their criteria that they're nationally renowned for patients, people who go through and master all these techniques. So that's the first step in terms of looking for an embryologist. Then internally within the lab, you'll have basically a lot of what Devin talks about in terms of managing the specifics of the lab itself. So someone who's going to be really meticulous in terms of making sure you're maximizing the potential of that lab, culture technicians culture techniques, the environment the embryo goes in, managing the lab, so therefore there's a lot fewer drop-offs in terms of the embryos themselves. We're looking at not just temperature, but carbon dioxide content. All those things are going to be really important in terms of making sure you can manage the environment that the embryos develop in. And then they have to have capability in terms of identifying eggs. Because someone may end up having 20 to 25 follicles, an embryologist may only identify 10, but that's because they don't have experience in terms of distributing and removing the clots that may be there that contributes to the process itself. So being an embryologist is a lot more than simply just being able to write notes and take criteria.
Who is the person who decides which embryo or embryos to transfer? Is it the RE or the embryologist?
Many times it's a conversation between the RE and the embryologist, but we're going to defer to the embryologist because they're the ones who make or are looking at the embryos in real time. And then more importantly, and we'll talk about this when we talk about genetic testing, but we're looking at genetic testing being a really key part in terms of making the decision in terms of which embryos to transfer as well.
And going back to the actual process itself, could you just explain a little bit more about IVF versus ICSI for those who aren't so familiar with it, please?
I'll go through and talk about some of the history involved with everything first, so therefore it will actually have a little bit more information just in terms of what people consider. IVF is in vitro fertilization. That's the first technique that was developed in terms of basically stimulating the ovaries, getting the eggs. Initially, before sperm was actually looked at as a factor, you simply took a certain amount of sperm. Typically, it's going to be about between 50 and 100,000 sperm, putting it directly on one egg or a group of eggs and have it fertilized naturally. So that's the IVF process where it's in vitro fertilization. We don't really interfere with that fertilization process. It happens on its own, if you will. ICSI is intracytoplasmic sperm injection. That's where it was developed originally as a technique for men with very, very low sperm counts, enough to where you're not really going to see 50,000 sperm. But it allowed men to, or if you're looking at testicular sperm, and you're basically taking one single sperm and using that to inject into the egg itself. And therefore, it allowed men who didn't really have the capability of basically parenting in the past to now have their families. And it also came about when we started doing some testing to see, does that improve pregnancy rates? It looked at older women and seeing if they had better embryo development. And so therefore, as Devin said, we use ICSI far more now than before, because it allows us to have more embryos to look at, more embryos to deal with, and it helps in terms of identifying embryos to transfer.
And for sperm selection, how does ICSI help with that? Especially, I presume, if the sperm has been frozen.
Yeah, so ICSI actually allows you to select the sperm, right? Where you don't get that option for standard IVF. You just introduce, hundreds of thousands of sperm to the egg, right? So with ICSI, we're going to select one sperm. There's a criteria that we run through, which was based, when ICSI started back in 1992 on how to select sperm. There's different things you're looking for, but basically whether the sperm has all the parts to make it work, how it moves is important. So we're going to select the best sperm, that we think has the best chance to fertilize the egg. And again, you don't get that option with standard IVF.
And what about thawing of frozen eggs, sperm, and embryos? You mentioned that you have a very high success rate for thawing. Is that the same with eggs and sperm as well?
Embryos do the best, I should say. With sperm, you have millions of them. And so it's not that important to keep all of them alive. With sperm, generally, half of them basically die off during the freeze thaw process. And normally that's okay. It doesn't, affect that live cohort at all. And those do fine in IVF. And our egg freeze thaw rate is pretty good here. It's about 92% survival rate. And so it's always going to be a little bit lower than embryos, just based on the nature of the egg and versus the embryo, but still pretty good. And egg freezing is something that has improved dramatically in the past, I would say, 6 or 7 years. So it works out much better now than it used to.
Following up on that, just in terms of both the freeze process and the sperm is the smallest cell in the body, egg is the largest cell in the body. Embryos are in between. And then the difference is just that when you're freezing, you're actually removing all the water content from the egg and replacing it with the best way to think about it is antifreeze. And the process of basically freezing the sperm, then removing the antifreeze and basically re-expanding and thawing it, that is one part. In the past, everything was done what we call a slow freeze technique. And that's actually one of the things that contributed to the poor survival in terms of eggs and embryos. And now, just like Devin described, we're doing what we call a vitrification or a rapid flash freeze technique. More eggs and more sperm and more embryos survive the rapid freeze and thaw than with the slow freeze. So therefore, looking at eggs in general, when first we started doing eggs and embryos, you needed between 15 and 20 eggs per pregnancy when we were doing the slow freeze technique. Now, depending on the age and depending on some other factors, you only need between 7 and 10 eggs per pregnancy from a frozen cohort. So you can see that the technology is actually different, the capacity is different, and also the freezing mechanisms really, really help to need fewer and lose fewer eggs.
Embryo grading, you obviously have touched on that earlier, and the quality and what that means. Should people get hung up on the grade? Because I hear of a lot of people, and I think I was one of them, where I found out the grade and then I thought that it may have been doomed, before the cycle had even finished.
The simple answer is no, I wouldn't get too hung up on it. And it's only because we see pregnancies, like I mentioned, every month here from C grade embryos, right? They do implants, or they have less likelihood of implanting than an A embryo. That's just true. It's just the reality of it. But I wouldn't get too hung up on it. And there's a lot of other metrics that we're looking at now, like the genetics of the embryo that has, it's much more predictive than the embryo grade in terms of implantation.
How would you advise someone on whether to freeze eggs versus embryos at 39 years old, especially if they're using donor sperm? What generally is the option with the highest success rates?
Well, what I was going to say is I think Dr. Smyka would agree with me that freezing embryos is, of course, going to be a better option there, just based on the difference in survival rate that I mentioned earlier. Embryos tend to do better freezing and thawing than eggs. If you're going to do fertility preservation, it's better to do it, freezing embryos than eggs, if that's the option for you, if you're going to use donor sperm.
I'd probably answer it a little bit differently, looking at it this way. It depends on what your entire goal is. So therefore, let's say using the same parameter, 39-year-old, looking at preserving their fertility, and they're either using donor sperm because that's a choice, or they're using donor sperm because they want to basically maximize their chance for success, or they want to know the difference between that and then what to consider in terms of freezing eggs at all. The thing I would actually say is just that in freezing eggs, what you're doing is you're basically making an insurance plan for the future without really knowing any information about how those eggs are going to do. And again, Devin said that only 92% of them may thaw, so that means you're going to need to freeze more eggs to basically give you that same opportunity in terms of getting pregnant. If you're freezing embryos, you freeze an embryo, you know the quality of the embryo, you know all the information about that embryo. You can even go further to do genetic testing on that embryo. So you now know what the genetics is of that embryo. So therefore, if you want it to actually be the most certain, you want to get the most information possible, and that's freezing the embryo and doing the genetic testing so you know what's in the bank. So you have in one circumstance where you don't know much information other than you have some eggs frozen, versus you end up having some embryos that are, let's say you did genetic testing that are euploid embryos. and that means you have the highest implantation. The difference is just that if you're in a situation where you're not really in a part where you're considering fertilizing those eggs because you're trying to preserve that opportunity for a partner that you're going to have in the future, then I'd say what you may want to consider is putting more eggs in the bank, if you will. So putting as many as you can or as feasible. So you're going to try to maximize the chance that you're going to be able to actually get a better success in the future. So going back to those same numbers, it may mean freezing, say, 10 or 15 eggs for every pregnancy you're planning, hoping that, you may end up having more, but at least you'll end up having that potential in the future in terms of being successful. So let's say, you're 39, you have normal ovarian function, ovarian reserve, you're planning for 3 kids. What you may want to do is to consider freezing 30 or 40 mature eggs. So you'll have an opportunity to fertilize all those, hoping that you'll end up having those 3 or 4 normal embryos for you to get pregnant. So that's that drop off that Devin talked about. So you're going to end up having a lot more in the bank. So therefore, in the end, when you do basically find that either donor sperm or with a partner, you'll end up with that same number. So you may end up having to go through one cycle, get that same information, fertilize everything, and come up with those same 2 to 3 by fertilizing it now, or basically getting a lot more, feeling some uncertainty, but is hoping you're going to end up having some in the future. So that's the difference in terms of thinking about it, with a partner or with donor sperm.
Before we move on to PGT, because we do have some questions on it here, what are the main causes for complete fertilization failure, and how common is it for not a single egg to fertilize in a cycle of IVF with a good retrieval?
We see complete fertilization failure here in about 3% of IVF cases, normally in cases with very few eggs. So these are cases that unfortunately end on day 1. So it happens infrequently, but it certainly does happen. Why it happens is difficult to say. I co-authored a paper a while ago that was titled What to Do When ICSI Fails. And we looked at a bunch of different reasons why this might happen. The most promising solution we found was that it wasn't necessarily a sperm problem, was that the eggs failed to activate. And so we introduced a technique called assisted egg activation, where we put calcium in with the egg and allowed it to sort of artificially activate. There was some promise to this, but it's a tough situation. It's difficult to say while it happens. There's some testing you can do to the sperm, like DNA fragmentation testing, might tell you whether you need to find a different sperm source, that the sperm is just incapable of fertilizing an egg.
The other thing I would say is just that, well, we're making the presumption that basically all those eggs are mature. So we do have a situation where we're looking at things from a clinical standpoint. By every measure, it looks like you'd expect to have all mature eggs when you do the retrieval. Yet when you do the retrieval, you end up having a significant number of eggs that are immature, because everyone actually has a different way in terms of how they respond. And that's going from the data where you're looking at a large number of people to the individual where you're not behaving the same way everybody else does. So the same person will end up having 10 or 15 follicles that are actually in that range. We look at 13 to 20 millimeters. You get those, you'd expect to end up having, say, 7 to 10 mature eggs from that group. And there's some people who, in that same cohort of eggs and follicles, will end up having no mature eggs. In our situation, we think that that's actually a part of the biology of what's going on in the individual. So many times, if you change that parameter, you can actually improve fertilization rates by getting more mature eggs. The second part is then, how do you end up having fertilization failure in terms of patients who have a lot of eggs that are mature? And just as Devin said, that you may actually do with egg activation, but there's sometimes when patients actually have some underlying diminution in their ovarian function or ovarian reserve. So therefore, those eggs, even though they're actually mature, they may not fertilize well, or they may end up rupturing during the time when you're trying to fertilize them. There's something inherently going on inside the eggs themselves. Those are the hardest ones to overcome, because that's a biological issue that we just don't know. So I think it's a hard question to answer, only because, number one, it doesn't happen as often as we hope. It doesn't happen very often. But number two, it varies from cycle to cycle. So you can't say it's going to happen the next time.
And what about age? Whilst we're talking about success rates, what about age and also fresh versus frozen success rates?
Age is actually an easy one. The American Society of Reproductive Medicine, ESHRE, all those groups actually have published data to show that when you're younger, you're going to end up having more eggs that are going to end up being genetically normal, and therefore the pregnancy rates are going to be much higher. As you get older, then there's going to be some decline in that function. And after age, I'd say 39 to 40, it starts dropping off even much more quickly. After 42, it drops precipitously. So therefore, even anywhere around the world, there are fewer pregnancies for women who are, say, 44 or 45 using their own eggs. The best way to think about it with less than 30, and that's one of the reasons why we think about using women with younger or for donor eggs. You may end up having, say, 5 or 9 or 10 out of each cohort of 10 eggs be normal. At 30 to 32, that drops off to 8 out of 10. 33 to 35, it drops out to, say, 7 out of 10 or 6 out of 10. 39, it drops to 5 out of 10. By the time it drops to 40, you're talking about maybe 2 out of 10. 42, 1 out of 10. 44, 1 out of 20. And so you can see as the number of eggs decline, then you're actually putting just statistics in it. And that's the reality in the biology of what goes on.
What about fresh versus frozen?
When you're younger, you end up having a much greater potential of transferring fresh embryos. We're finding out now that one of the things that is happening is just that during the stimulation process, there's a lot that's going on both inside the uterus and inside the ovaries, and they don't necessarily work in concert. They may work separately. So therefore, if you're looking at things from that perspective, you may end up having eggs that are actually either, or embryos that are too advanced for, or not going to do well in transferring it in a fresh environment. If you don't have a lot of embryos to begin with, or don't have a lot of eggs, then it may be less likely that that's a factor. But that's something you have to kind of consider.
A question that people must ask you a lot. Why don't some embryos implant? What can people do if they can do anything to increase the chance of implantation?
It's a question everyone's trying to figure out in this industry right now. 30% of embryos will not implant for reasons that we can't explain at the moment. Embryos that have been tested genetically. If you're looking at just across the board, the number one reason that embryos don't implant is because the embryo itself is genetically abnormal. If they've been tested, not all of them will implant, and a lot of times it's for reasons we can't totally explain. There's a communication process that has to happen between the endometrium and the embryo that simply doesn't happen for 30% of these embryos that we transfer. And so everyone's trying to unlock this key right now to try and facilitate this communication and prove this in our field right now. So it's an interesting, exciting area, improving the implantation, but it's difficult to explain.
That leads me on to the next question that's come in tonight. What are the key numbers to look for when comparing success rates? The SART data US clinics post is confusing.
I agree with you there. They don't make it very easy for patients to understand that data. There's a bunch of different ways you can look at it. Basically, what you want to do is, you can break it down by age groups. You can get to your kind of situation and see what the success rate is and compare it to other clinics, I think, with the SART data.
Again, thinking about picking a clinic, how would you advise establishing how good the embryologist team is at a clinic, as we've talked about how important that is?
I would go by the success rate of the clinic and attribute a lot of that to the lab itself.
Now we'll move on to some questions on day 3 versus day 5. What's the difference between freezing on day 3 versus day 5 and even day 6?
So we mentioned before that embryos do better than eggs. And when I said embryos, I was talking about day 5 or day 6 embryos. And so basically think of a day 3 as in between a day 5 and an egg, right? And so the success rate is going to be somewhere in the middle there, closer to a day 5, but not as good as a day 5. As Dr. Smykel mentioned, it has to do just with the biology of what's happening and the size of the cell, essentially.
Sorry, I was just going to say, Dr. Smykel, I'm aware that we don't have you for much longer. So is there anything else you wanted to add before you need to disappear?
And I think, the key thing in terms of looking at this and just talking really specifically about SART information. I think one of the things is just to realize that many places will either use information or factor, patient success in terms of trying to basically, provide better information, if you will. I think the important thing is to be focused on your situation rather than a generalized number, because what you're looking for is someone who's going to pay attention to you as an individual and try to provide more information about your care, rather than actually going to some place that is may even not accept you as a patient just because of the impact of some of the parameters that may be. Especially as you get older, that may impact the chance of success as well. I look forward to helping anybody we can, and I apologize about jumping off earlier, but unfortunately, being in a clinical situation, then you end up having to see patients. So
here are Laurel Fertility Care's contact details, and Dr. Schmeichel would welcome any further questions if we haven't had a chance to cover them tonight. So please do contact them directly, or you can message via Fertility Help Hub, whatever you feel more comfortable about. We do have a few questions remaining about PGT. I don't know, Devin, whether you have time to answer some of those, or if not, we can have people message them over and get in touch directly.
I think Devin should be able to answer those, but I'm going to jump off. Thank you again, and thanks for the opportunity.
So really the questions are around day 3 versus day 5, and also PG testing. In what scenario would you use PGT testing? Is it for everyone? And what does that mean for success or helping success rates?
Day 5 is favorable to day 3 for sure. Almost all the embryos that we freeze are on day 5 or day 6 here at the blastocyst stage, right? It's because they do better. And I mentioned it's because there's a drop off between day 3 and day 5, right? Some of those embryos arrest along the way. If you freeze on day 3 with the intention of thawing and transfer, you don't know if it's going to make it to a blastocyst. So you freeze sort of before that natural selection process that happens in the dish. Day 5 and 6, highly favorable, right? So almost, like I said, almost everything we freeze is day 5 and 6.
Who were testing before?
The literature is not consistent about this, the scientific literature, right? I think most clinics, including ours, are recommending testing for anyone that's 37 and older for sure, right? It will increase your chances undoubtedly, the PGT testing. And that's just based on what Dr. Schmeichel reviewed before with the diminishing percentage of normal eggs in women that are aging, right? It's going to be, 15, 20% when you're 40, and it's going to be 60, 70% when you're 34, right? So that window. So that's why the PGT testing is so, works so well, especially in women that are 37, 38, 39 years old.
And should people be worried that it might be detrimental to the embryos?
No, it's really not. There has been a few really good non-selection studies that have been done where they take embryos that have been biopsied, compare them to embryos that have not been biopsied. Even though it does look invasive, the procedure that I showed you that video of as I mentioned, if you looked at that embryo in about 30 minutes, you wouldn't be able to tell that I took 5 cells out of it. They just bounce right back. So it's really not harmful to the embryo at all. I wouldn't worry about damaging the embryo by doing testing.
And what chance is there that an embryo with a chromosomal abnormality implants if you did a day 3 fresh transfer?
Well, there's certain abnormalities that will implant, like trisomy 21, which leads to Down syndrome. There's certain abnormalities that are not going to have effect on implantation, unfortunately, right? But the majority of the time, this abnormality in the embryo is going to cause it not to implant.
Or could it lead to an early miscarriage even if it does implant?
Or an early miscarriage, not lead to a viable pregnancy, is what I'm trying to say.
Do you grade day 3 embryos?
We do. It's not as intensive as the day 5 and 6 blastocyst, because there's not as much there to grade, but we just grade it number of cells, basically how even the cell size are, and if there's any fragmentation around the embryo.
What genetic abnormalities do you test for in the embryos?
So we're not looking for specific genes, right? We're just looking at a broad overview of the genome, right? So we're looking at all the chromosomes, and now with new technologies in DNA sequencing, we can look at very small pieces of the chromosome to see if everything's there and everything's in the right place, but we're not looking at specific genes.
Well, thank you so much for your time today, Devin. Does anyone else have any last questions? I think we've covered most of the things. Apologies if I have not covered off any of the questions, but as you can see the contact details there, please do get in touch. And people have said how extremely helpful this was. So thank you so much for your time. It's been fantastic.